People will be joining. I'm just going to start a little bit now. Tonight, we'll be talking about opioid-sparing techniques for sports medicine and shoulder procedures. The authors were Parth Kamdar and Paul Sethi. Paul is here tonight to discuss the articles. I'll be letting people in as they come in. I do want to say that this was an extraordinarily popular article, 835 views, which puts it in really the top 10 to 15% of articles in our journal. Just to give you a perspective, the average journal in JBJS or Journal of Orthoplasty gets around 65 to 120 views. So this is a very, very popular and very well-read article, beautifully written, I have to say, and was the unanimous choice by the board, the review board that reviewed it, and everyone wanted to review it. The journal, as you know, publishes articles on a regular basis. This is one we published today by Brian Kelly at HSS, and we do that. For people who want to submit, you just go to four authors and click on submit a manuscript. We do have some advertisements here from some companies. You just submit a manuscript and it's just that simple. And if you would look at this, you'd see that in the 2 years we've been in publication business, over 100,000 page views and almost 50,000 unique visitors, which is particularly good. So I'm going to stop the share and I'm going to go on to Paul. Paul, I'm going to start off a little bit right now and really pretty much say, what was the reason for you kind of to begin to look at this issue when you first got started looking at this issue of changing the way you look at pain in sports medicine procedures?
Well, I think first of all, congratulations on the journal and hitting the 100,000 number. And I'm even more impressed. I didn't realize that metric of how few people will review or read an article that I submit to JBJS. So I'm really excited about that. My motivation to sort of start this, I guess, has a lot of beginning factors. The first thing is that rotator cuff surgery historically, and that's an important statement, hurts a lot. And I didn't go into spine surgery because I didn't want to have tons of pain post-operatively and have to follow patients and realize that they were struggling. But as it turns out, the rotator cuff surgeries that I did when I first started practice, and perhaps there's a learning curve, but 18 years ago hurt a lot. They'd come in at post-op day 7 or 10 and tell me that this was a miserable experience. And that experience stayed miserable for 6 weeks sometimes, if not 3 months in certain patients. So I recognized that I had a problem, and whatever I was doing, getting ahead of the pain, giving them pain medications preemptively, that wasn't really an effective strategy. And at the same moment, I'm operating on a lot of vulnerable people meaning young athletes who have had their identity stripped because of being taken out of sport vis-a-vis their labrum or ACL. And now I've got this conundrum of I need to treat pain. The world has taught me that pain is a vital sign and I must stay ahead of it. And I'm over-narcotizing these patients. In comes the recognition that actually these opiate medications are not just solving problems, they're creating problems and killing people. And I'd read in the newspaper every day about another youth in my community that died. Right? It just didn't make sense. And I felt really good that wasn't me. I never gave pain medication for anyone other than surgery or a bad fracture. I was really responsible. But as it turns out, 20% of patients after rotator cuff surgery are on pain medication at 6 months out. As it turns out, many of these kids who've gone down dark pathways started out with appropriately prescribed medications that subsequently became diverted and were part of the problem. So I guess it's a long preamble as to I had a problem with controlling pain. I had a resource that really wasn't appropriate, and I have a vulnerable population. So the world was begging me to do something differently, and I just had to. It took me a couple of years to figure that out.
So what right now are the base tools that you use? What are the building blocks of the pain management tools that you are currently using in all your sports medicine procedures? What are sort of each of the different items, and then we'll talk about how you're using them and how you're protocoling them.
So each of the items are really important. And I think that any one item in isolation probably isn't sufficient or may not work as well as this sort of cumulative process. So part one is, fortuitously, I live in a community where patients are educated and come in with certain expectations. But I go on further and I go into education. I think that education is the first pillar, recognizing, one, that these medications are dangerous, but two, a little pain is okay. Pillar two is going to be Pillar two is the requirement for preoperative preventive analgesia.
Right.
Pillar three is for intraoperative medications that are going to mitigate and reduce the pain. And that's where a medication like Exparel will play into a role. And pillar four is, again, appropriate modalities, ICE, PT, post-operative anti-inflammatory medication, and again, post-operative reinforcement that we don't need to rely back or fall back on a stronger pain medication. So I think it's all of those things together, and one in isolation, I don't know, is adequate.
So first of all, let's talk about education for a second. Who does the education in your office? How does it get done? And are you educating them about pain, what to expect? What is the whole thing?
So education is going to get done and reinforced by all of us, right? It'll get done by myself. It'll get done by my PA, who's going to help me in the pre-op. And then everyone who's on my team, including my coordinator, knows that we really want to rely less on the opiate medication. And I'm not this nihilist where I say, no, you can't have it. Or I don't say, gosh, it is the wrong thing. I'll kind of challenge them, especially with the athletes. I'm like, look, we'll give you some, but you're a pretty good athlete. You're not going to need this. Or you're pretty tough. I could tell. You're not going to succumb. I'll bet that, the guys on your team didn't need it. You won't either. We also have made a video, right? And it's a video where it's 2.5 minutes. It'll get played at the pre-op visit, and then we'll push it to the patient the night of their surgery. So there's lots of reinforcement of this idea. There are two different studies, one from Rothman Institute looking at shoulder specifically, where Luke Austin demonstrated that education alone reduce the opiate consumption by 25%. So he did another study where he put the prescription in a sealed envelope and said, only break this if you need it. And once again, patients just don't break it. If you set a challenge or make it exciting for them, it becomes they get engaged.
So I'm going to share just a screen from the article. Current opioids prescribing habits are inconsistent, 5-fold range, from 12 to 60 pills. What do you think's going on there?
Well, a lot of things. Michael Redler, who's on this call, may remember we were at dinner in New Haven, and I went around the room and I asked people after a simple knee arthroscopy, how many pills do you give? And Michael was one of the last ones actually to respond. And I was getting a lot of 40s. And then there was a couple 20s, and then there were some comments. And Mike's like, none. I give none. You don't need it for that. So in that example, we had 0 to 40. And why is there such a variation? Really, knowledge on how to do this is passed down. It's passed down from the resident to the chief resident or whatever you'd learn to do. And formal education about how to prescribe and treat pain postoperatively has really been relegated to a secondary component of surgeon education. So as a consequence, we don't have those standards.
So in the issue here in your article, I'm going to bring this up right now. Sorry, it's taking a second. There we go. All right. You point out the education in the article, okay? But now in looking at all the shoulder operations, the rotator cuff repair, the labrums, the total shoulders, there's got to be a range of how many opioids in each of those. I mean, I've got to imagine the total shoulder or reverse shoulder has got to be more painful than a rotator cuff.
So I love that you said that. It's the exact opposite, right? As it turns out, and that's, by the way, my patients believe that, other subspecialties believe it, but shoulder replacement is a very low-hanging fruit. These are older patients who have a lot of pain, who've learned to manage their pain. And post-operatively, it's kind of like a hip replacement. You get rid of that bone-on-bone pain. And yes, you can be sore, but it's a different level of soreness. So really what we had to do is challenge ourselves and ask us how many are needed. You're right. There has to be a range, and patients are going to have comorbidities. So patients with depression and patients with anxiety or a previous history of opiate medication use, like that's going to be a challenging group, and we're going to have to fight through that in a very different way. But the generally opiate naive, and I mean opiate naive, not having medications for the last 3 months or so, the opiate naive patient, we needed to create guidelines, and that's what we set out to do about 5 years ago. And we pressed ourselves. When Exparel came out, I had a pesky rep who was telling, you got to try this, fall. You have to try and use this. And I said, look, it's not going to work with my arthroscopy. I can't get injected arthroscopically. And she said to me, well, you better figure it out. Like, this is a good idea, and you're missing an opportunity to treat people really well. So I credit Laura Wynn with sort of pressuring me down the pathway of trying to understand how to use alternate medications in the setting of arthroscopy. But we asked ourselves, Ira, so the first group of studies we did were retrospective studies, where we went back and looked at how many they took. And a lot of those retrospective studies didn't want to get published because, look, anyone can do a look back. There can be recall bias. There can be all sorts of things left over. But once we gained a range that we saw people were taking retrospectively, then we went ahead and did the prospective randomized studies. And prospectively, we said, look, we're going to limit to this many pills. And then we did pill counts, and we were really aggressive. So there was no recall bias. And we found that, when we gave 25 pills, they needed few, they didn't use them all. Now we give 15 pills, they don't use them all. But really, I think that's my magic number, 5 to 15 for a shoulder procedure, right? For a total shoulder, for a reverse shoulder, for a rotator cuff, and for a labrum. And rotator cuff, at least in my experience, is the most consistently painful, outside of perhaps shoulder fracture, which is also a painful procedure.
When did you start using interscaling nerve blocks routinely?
So interscaling nerve blocks have been a normal part of what I've done since I've entered practice, I guess 18 years ago now. I can't believe 18 years. That's been a blink. What I really loved about the interscaling nerve block is that we had a reduced need for anesthesia. Patients were less drowsy, less nauseated. They felt good. They were able to go home same day from surgery. But there was this thing called rebound pain. And rebound pain was when the nerve block wore off somewhere at 2, 3, 4 in the morning. Their pain came screaming back, and it didn't go to a 6 or a 7, but it went to like spinal tap. It went to an 11, right? And it went to an 11 in a way that patients had a really hard time catching up. And they would routinely call the office. Some would go back to the emergency room. And if you're thinking about like the quality of their surgical event or the episode of care and the cost of care, if they go back to the emergency room, you've completely just pooped in the boat on that one.
Right.
So this rebound pain was a real challenge. To respond to rebound pain, take two narcotic pills the minute you get home, and take them every 4 hours. And now they were constipated and had burned through 10 pills before they may have even needed them.
So, we just submitted a publication on joint replacement revisits to the ED. Okay. Have you noticed, since you started the protocol that you published in the journal, a decrease in either calls to the office or ED visits, a variety of things like that?
So we track that, right? And that's an important part of what we have to figure out. So call reduction after ACL surgery, there was a mean of 3 calls over a 2-week period for these patients, right? So that's still that's a relatively small number. And we unfortunately couldn't sort of discern whether that was a call about PT range of motion, but the pain calls were very, very few. Visit to the emergency room. I've gotten to the point now that if a patient actually comes in and tells me that they had pain after surgery, I'm actually surprised. Pain at disproportionate. If someone goes to the emergency room afterwards, I'm really worried that something untoward has happened. It would be not a 1 or 2 standard deviation outlier, but much more than that. So It really it's changed everything, but maybe to the point where I'm more annoyed with when I have pain than sort of compassionate as I should be.
So what has been the advantage for you in your experience of the use of liposomal bupivacaine in the interscaling blocks? Have you seen it? Because there you wrote in the article that there was some equivocal data, but most positive. What's been your experience in using that in interscaling block?
So we initially started using a field block, a block where we would just inject it. And I was actually injecting into the suprascapular nerve distribution and the axillary nerve distribution. And the field block, let me just be honest, and our pain scores are, reflect it. The field block is not as effective as an interscaling nerve block. The pain scores in the PACU were a 3 or a 4, which are tolerable, as opposed to a 0 or a 1. So the field block was good, but it's not as good as an interscaling nerve block. And we didn't have FDA clearance for it, right? But now I use a small volume. I use 10 cc's. My anesthesiologist does it. I don't have to think about it. It's actually there preemptively. So if I believe in any sort of preemptive analgesia, it's done for me. And going back to this rebound idea, rebound pain is gone. Since it slowly sort of trickles off, it's got a much longer effect, and we see it last pretty consistently to 48 hours, not always 72, but consistently to 42, 48. We just don't see that rebound. They're not coming back and saying, "Oh my gosh, this has been transformational." So in and of itself, it's solved for that major problem. The other thing is that if we look at all the studies, whether they're our ACL study that we just presented at the Academy this year, or our rotator cuff, or our total shoulder study, you look at the area under the curve and look at their pain scores, and the total amount of opiate is reduced by near 50%. So they don't need as much, and they get to ride in first class like you and
Redler.
And Redler. Sorry.
Yeah. Yeah, I wouldn't expect him riding in first class either. That's why I would have paused. Those Connecticut guys, you don't know that. You don't know that. There was a question that came through to me privately on the chat, which was, what about all the other things such as, the Tylenol, the NSAIDs, the gabapentin, when did you start using those? Did you notice have you done a study to remove those from the whole protocol?
That's a great question, and I think the first response to the question, at least if I can, since I have the mic, I can answer things. I'm like a politician; I can say what I want. The first response is that I think those things are absolutely necessary, and if it just the same as education, if you don't have an appropriate multimodal approach towards this, then you're in trouble. So let's talk about each one of those 3 medications in a slightly granular way: the acetaminophen, the nonsteroidal, and the gabapentin. Well, I'll go with the lowest hanging one, right? The gabapentin. Gabapentin has been debated back and forth in the joint literature. Does it help? Does it not help? Does 300 milligrams HS never reach a therapeutic effect of medication? And it just doesn't make sense from a pharmacologic medical standpoint. That said, it works. It outright works. It gets you, the anesthesiologists, when I started using it, they're like, your patients may be drowsy at night. And I said to them, they can sleep at night. That's okay. So it can cause some drowsiness, but not at that small dose. So we've really been thrilled with it. And in fact, when patients do have more pain, or their complaint is that they are having some difficulty sleeping, because it's not, of course, some people are going to have a little harder time than others. We'll refill their gabapentin before we refill anything else. And the gabapentin at night can really be helpful. And if I have to go to BID, then I can go to BID very easily. So we've looked at the literature. Once again, lots of debate back and forth. Low dose seems to be very effective. The next one. Oh, someone said a question?
I will say, Paul.
Oh, okay. No worries. That's just something in the background. So the next question.
No. Neil just said he gabapentin, I thought, was useful, right, Neil?
Yeah. Look, the gabapentin is a major piece of pharmacology. It's controlling a lot that's going on in the central nervous system. So it's not surprising that it's works. And it's also enormous adoption outside of the primary
So, I mean, very helpful. Look, for someone who sort of is a firsthand, I think that's helpful. The next sort of medication, non-steroidal. Well, in tendon healing surgery and some ACL and rotator cuff or surgeries where we're worried about healing, there's some kickback or concern about using non-steroidal. Well, as it turns out, there's no study that shows that if you have non-steroidal use for between 3 and 5 days post-surgically, that you're going to have a long-term effect. And that's actually been looked at in longitudinal animal and human studies in rotator cuff, as opposed to the continuous for 6 weeks, which may be a problem. So if we consider the first 3 to 5 days, and really it's 3 for most studies, but the first 3 to 5 days is the window where you need to get pain control. If you can get pain control, then the patient will in perpetuity have a better experience. So that's where the non-steroidals are great. And as orthopedic surgeons, we know that non-steroidals are great for bone and musculoskeletal pain. So that'll be a very consistent part of what I use in that period of time. After 3 days or 5 days, I think a lot of patients' stomachs can get upset anyway. So I'm happy to get it off in my elderly patients. And I'm also happy to get it off in someone with a massive cuff tear that I'm worried about. But that really helps a lot. And finally, the acetaminophen, just because it's over the counter doesn't mean it doesn't work. And we're going to use consistently 1,000 milligrams TID for the first 5 days. And once again, if we really blast them with the medications and stagger the anti-inflammatory, the non-steroidal, and the Tylenol so that the peaks and troughs don't hit at the same time, we've been really, really effective in helping the patients. So those are the 3 sort of stalwart medications that I use for any surgery that's very painful. I don't use the gabapentin, for example, in a knee arthroscopy. I think that's probably overkill. I avoid the gabapentin in the kids who are under 15 or 16, just because I don't know that I have enough collective experience with that medication. And then going to the nerve block, right? The nerve block is just about an always. It's just about an always, and it's an interscalene nerve block. You guys will be interested for my ACLs, and I haven't published this yet, but this is coming. We have routinely used an adductor block, right? We've gone away from the femoral nerve block, just like everyone else, whether it's rather total knee or knee arthroscopy, because we want femoral nerve to come back fast enough. But I found that the adductor block, even with Exparel, isn't always enough. And then I was doing some local field infiltration. But once again, there's a lot of sort of time, effort, remember to technique with that. Now I've added, instead of that, a superior and a lateral geniculate block. And those are field blocks, right? And those are blocks that you as a surgeon do at the end of the case, 3 finger breaths above the patella. You come down to bone, just come off, and you load, you field block 10 mLs there, and you come in laterally, right where your guide pin might come out in an ACL, or where you might make your secondary incision to insert something, and you field block it there. And that, when you add that field block to an adductor block, you get really comprehensive coverage of the knee, at least arthroscopically, and perhaps don't need to go to something more sophisticated like an IPAC.
That's great. I'm going to take exactly a 3-minute break because we have a sponsor for this session, which I have to respect. All right. I'm just going to play a short movie. We have the pleasure of this sponsorship by Gait Science, a new company. And I'm just going to play this.
Gait Science, safely silencing pain. Pain after orthopedic surgery is severe in the first few days and can persist for weeks. Following discharge after orthopedic surgeries, such as total joint and rotator cuff procedures, opioids become the cornerstone of pain management. Each year in the US, 2.4 million post-surgical patients become opioid dependent. 2 gates control pain transmission from the periphery, the molecular gate and the synaptic gate. Pain is transmitted through afferents that synapse onto secondary neurons in the dorsal horn, which in turn carry the signal to higher centers. The molecular gate closes with pharmacologic blockade of the sodium channel, commonly used with nerve block. The synaptic gate closes with neuromodulation, pulsed electrical stimulation, commonly used for treatment of chronic pain. Both gates can be closed with a single lead positioned next to the nerve trunk. The The Relay system is the first to combine pharmacologic blockade and neuromodulation in one multimodal device. An injection port delivers analgesic to induce primary nerve block. Relay's wireless integrated pulse generator provides neuromodulation via 2 electrodes at the distal end of the lead. There's a second injection port for treatment of breakthrough pain following discharge. Relay fits into existing workflow, and clinical deployment is as simple as performing a single shot block. Prior to surgery, Relay is positioned next to the target nerve and delivers primary nerve block. Surgery proceeds with Relay in place, outside of the surgical field. After surgery, neuromodulation is activated. Following discharge, the patient is in control. Instead of reaching for an opioid pill, the patient adjusts pulse intensity up or down via an app on their smartphone. Relay can be used for up to 30 days.
Okay. So screen time has stopped. Okay. Can you hear me okay?
Yep.
All right, good deal, good deal. So that was an example of another type of concept of nerve blocks. And you know that we're not going to switch to that topic, but let's talk a little bit about patient compliance, Paul, with your protocol. Have you found, I have a lot of problems in the South Bronx. We don't have a lot of patient compliance, with our protocols, and there's a lot of substitute of opioids because of the lack of trust of thinking that Tylenol or Advil is good enough. What happens in your practice?
Well, look, that's a really fair question. And in fact, the first submission that we sent to the Journal of Arthroscopy came back like, that's great. A bunch of patients in Greenwich, Connecticut can do better. How is that generalizable to the rest of the population? So we actually redid the study, and we included a group from Oregon and a group from South Florida. So look, compliance is a huge deal. And if the patient doesn't buy in from the get-go, it's gonna be an uphill fight. And that's why the buy-in has to be so consistent from me to PA to nurse to every single person. Initially, when we started doing shoulder replacements as outpatients, it would be amazing. The patient would be set. They want to be an outpatient shoulder replacement. They get there, and the pre-op nurse would be like, look, you should definitely stay. Your insurance will cover this. Why wouldn't you stay? It'll be better for you. So every single chink in my armor has been exposed in one way or another as I've sort of tread through this career. And that was another one of them that I really had to work through. But I am a little privileged at times with patients who are more likely to listen. But of course, I've got my share of non-compliance. I mean, most non-compliant ones are some of in my lax bros who are just going to smoke instead of take any medications. And like that could open up a whole nother discussion of, is that a reasonable and effective non-opiate analgesic? Right. That I don't know the answer to, but needs to be figured out.
So let me ask you a little bit about surgical technique and whether or not you feel that surgical time, how much fluid you use. We're talking about rotator cuff specifically. Okay, rotator cuff specifically. How much do you feel that the surgical technique and the surgeon factor plays into post-operative pain? A lot of people don't like to talk about it, but
So I don't know the true answer to that. Of course, I want to believe that I'm efficient and I handle the soft tissues very effectively, and all of those things that I may do are reasonable. But having been all around the world and watched people operate, I think most orthopedic surgeons are pretty darn. I mean, it's rarefied air already, and I don't want to be arrogant and say that, but they're a very reasonable, well-trained group. So I think that most of us can have the same guidelines. And it's interesting, our training protocols are very, very similar. So I have the privilege of working with fellows now, and the fellows come back from Colorado and Steadman Hawkins, and they're like, look, you guys are really doing all the same stuff everywhere. And they've trained at major residency programs. So yes, Ira, I want to believe that good surgical technique is going to play a role in that. But I think that it's just sort of like, when someone comes in and needs a revision surgery and you think that you're just going to do a better job right away. Well, ask yourself for sure, are you sure you're going to do a better job, or are you just going to do the same thing over and have that patient doomed to another problem?
So,
what do you think?
This plays into the discussion we had last week, and actually a question that Michael last week. How much of pain control is actually attributable to surgical technique, and how much of it is attributable to patient type? Which I think is something we have to get after if we're going to actually address this question in a meaningful way. And maybe it's all about, I don't know. Paul, what do you think?
Ira, could you repeat the question for everyone? Because
how much was related to a surgeon technique or patient type?
I mean, look, patient type and patient's expectations preoperatively are going to dictate how they do postoperatively, and some of their comorbidities, whether they have severe anxiety, depression, or other issues, are going to play a role in how they perceive and function with pain. So I believe that those are all factors, but those are factors that we don't necessarily control for, because depressed patients are going to still tear their rotator cuff, and anxious patients are still going to have problems. So I think that we have to learn strategies on how to help those patients.
I gave a lecture recently at the National Kaiser meeting, and I zoomed in Andy Wickline, who is a real specialist in opioid-free joint replacement surgery. And he said that the number one complication of surgery is anxiety, patient anxiety. What do you think? And he felt that education was the number one way to get rid of that anxiety.
So I don't know that. I'd love to see Andy's data on it, but of course, that the anxious patient struggles more, and those are the ones you have to just dove in with care and call them every other day and just really help them through the experience. And they're the ones who love you and endear themselves the most to you. It was a lot of work on both ends, patient and surgeon. But yeah, I think, look, it's got to be scary having surgery, right? It's got to be scary going through something you don't know what to do with and how to manage. But nonetheless, it's part of the job.
Let me ask you a side question. You are in a very active private practice. You are, and if I know this because I live nearby, an extraordinarily high quality private practice. How do you get the time to do the research?
I'm not, when I was in college, I had to run gels and look at chicken livers and do all these sort of hoops to get into medical school that I didn't really enjoy. These are problems, you asked me the question from the very, very beginning, like, well, how did I get into this? And it was a problem I thought I had. It was a problem I was facing. So I enjoy solving for problems that I face clinically. And that's, if you look at any of the research I've done, 80% of it's going to revolve around like how to fix the subscapularis better after a shoulder replacement, how to do something. And if you read between the lines, clearly you're going to read that, like, gosh, it's something that I struggled with, right? It's something that didn't make sense to me as a surgeon that I wanted to try and contribute to some slightly better answer on.
I get it. Where do you think, well, I got two questions. First of all, we still have an opioid problem. Not everybody's doing your protocol. We know 925 people or so read your article, so we know at least some of them will follow this. What do you think are the surgeon barriers to adopting this full force? Surgeon barriers.
I think the first barrier is that many surgeons in large practices may not even know about some of these inbound phone calls. They don't want to be bothered with that as a part of their life or a part of their practice. So it'll be a nurse or a PA who sort of has historical training and wants to appease the patient, and that's the first barrier. The second barrier is it's not that important to them. The surgeon is thinking, gosh, they have to identify who needs surgery, do a good job at their surgery. And that post-operative part, like, look, there's some education. We didn't want to get them behind on pain. And we're breaking knowledge gaps that we were trained in a certain way. We were trained that if we neglected to treat pain, that fifth vital sign, that we were just as remiss as the cardiologist who didn't talk to the patient about angina. So you've got to change practice patterns. If I told you, Ira, I think do you do an anterior or posterior hip?
I do a anterior.
So if I said you have to go, it's a little trickier, right? But if I said you can only go posterior right now, you'd be like, well, not to know, Ira, the data's out. You got to go posterior exclusively. You'd be like, well, I don't know. I've got a long history of doing a reasonable job. So I don't think very few surgeons walk around Dr. Death style and are doing things nefariously. They believe that they're doing a good job. So it's hard to change.
What do you
I
think?
have another question about barriers. To what extent is there disconnect between the anesthesiologist and the surgeon impeding pain management?
Okay, the question, if people didn't hear well, what is the disconnect between anesthesiologists and the surgeons in the area of pain management?
I mean, I can have fun and make the orthopedic surgeons laugh, and like the anesthesiologist doesn't see the patient after they discharge them ever, and it's all our problem, right? They just got to do their job. But at the end of the day, look, we're all aligned, and I think that if you can align your anesthesia team, like I fortunately did, they really work towards the same goals as you. That said, when we first marched down this pathway, when I asked all of my anesthesiologists what's in an interscalene nerve block, I had 6 different answers, and I had no idea. I had no idea at all that some people put clonidine, some people put Decadron, some people use 10, some people use 15, and the consistency of the approach and exactly where they put the block, that was different across the board. It was sort of like how each of us would have done some surgery that was allowed variation. So I think now we're working towards the same goals. And as we push more towards an outpatient presence, really our anesthesia team wants to engage with us and see that our patients do just as well in the follow-up. But of course, there can be some thought differences on how we approach the same problem. And those are healthy thought differences to help challenge us and to push us forward with different perspectives on the same issue.
Hey, Ira, can I ask thanks. So, Paul, you continue to be an incredibly elegant speaker, no matter what you speak about, and your message is spot on. A couple things I wanted to touch base with. It's interesting in terms of the anti-inflammatories. We always used to try and do Celebrex because it wouldn't cause bleeding and surgery, but the reality is that most of the insurances may require some pre-authorization or deny it as well. So we've actually gone to meloxicam as our anti-inflammatory because you don't have to get the pre-certification, and that works pretty well. I think that your message regarding the patient education is key. I think that you convincing the patient that this works great ahead of time is key. And I think that what we know is that the patient's personality and their anxiety ahead of time may be a big factor in terms of our success. It's interesting in terms of the concept of using Exparel as your interscaling block. I have patients that after 20 minutes freak out when they can't feel their arm and they can't feel their hand. And no matter how much you've talked about it ahead of time, they're saying, when's this going to wear off? And so a little my hesitancy to going towards, and I use Exparel for all my ACLs and for other procedures, but a little my hesitancy with shoulders is that same patient freaking out. Now it's 48 to 72 hours where they think they have no arm attached to them. Do you find that? And if so, how do you deal with it?
So that's definitely a real thing. And thank you, Michael, for the nice compliment, but it's definitely a real thing. And it's not just the patient anxiety. I did a complex revision of a reverse shoulder replacement last week, and I had to do a lot of work. And the next day I talked to the patient. He's like, everything's great. I can't really bend my elbow or wiggle my fingers. I'm like, oh, don't worry. That's just your nerve block. And I call him, the next morning. He's like, no, it's still not working. And at that point, I need to take anti-anxiety medications, and look, fortuitously, it wore off. So that anxiety level can go both ways. That said, to me, I think it's a 1 in 10 or a 1 in 20. I talk them through. The Exparel motor block doesn't last much longer, so it's a longer sensory than motor block, so it isn't as bad, but it could be a good day. And you're right, there is that group of patients, and I do my very best, and most of them end up tolerating it. But you're right, it's a hiccup, but it's a hiccup the same, because even if I don't use an Exparel nerve block, we'll use an interscalial nerve block with Decadron in it, which will still go 12 to 14 hours.
Is it anesthesiologist dependent how long the motor versus a sensory block lasts?
I don't think I know the correct answer to that question. Everything we can, look, there's certain anesthesiologists who, each of us love to work with. They make your day smoother and better. You never have any issues. No one ever gets thumb numbness afterwards. None of it, right? But I don't know that I've uncovered or figured that answer out.
I want to make a comment that Marty Nichols commented, and thank you, Marty, for this, that a lot of leading edge ASCs that he has seen for total joints have incorporated the anesthesiologist in the post-op pain management as well, not just in the OR. And we may see that. I mean, I think we may see that in the future, that we pass on post-op pain management to a group run by the anesthesiologist to take it through the third or fourth day. I mean, it's a surgeon's dream sometimes, I guess.
I mean, look, we had it at one point when there was pain services, right? When the anesthesiologists were getting reimbursed for pain services.
Right.
So if we turn around and look at the bundle, and part of our bundle, if we're going to share a part of the pie or the risk with our anesthesia team, and we engage them in helping with the post-operative pain management, I think it can be useful. But it's one of those scary levers or controls that I want to be careful to help manage as a surgeon, because if there's something impending like a compartment, I don't want anyone to ignore or blow off the small little minutia that could be important triggers to me. So it'd be great, but it's something I'd want to really trust. It's a lot of trust there.
So this is your protocol now. Oh, so Neil, question again?
Agree, Paul, but the level of attention that could be given with appropriate focus in that circumstance might help you out. And it might not be all you thinking about it.
Well, and you're right, Neil, as we develop new technologies that can help us for more than 3 to 5 days, and as we look at what Gate's going to bring to the world, I think that's where we're going to need the team of surgeon and anesthetist to really sort of shepherd us through the entire experience. And that might be the next gate, or if it were transition to how we effectively manage 30 days of pain post-surgically.
So if you could try to put your hands on the crystal ball, what's the next world of pain management? Where is that going?
Was it Niels Bohr who said, I'm not very good at predictions, especially when they're about the future.
Yeah.
So that's me. I don't know that right answer, but look, I think that we're going to get to a point surgically where we either have enough robotic interface or enough enough interface that we can minimize the trauma to the tissues. I think we're going to simultaneously somehow harness the biology of healing so that we can expedite these things. And then you're going to add in the next generation of how to modify your pain response, whether that's going to be controlling the nerves at the efferent and afferent level, or coming up with more supratentorial mechanisms on how to eradicate or tell your brain to shut off those pain strategies. So I think that our kids who end up being surgeons will look at what we did as barbarism, and there's only upside. It really will be Star Trek type, where you're holding little monitors over people and figuring this out. And I don't think it's that far off.
And I do think the supratentorial is the next big understanding. And you can do great things in the peripheral nervous system, but we really have to start understanding patient type.
I agree, Gail. So let me ask you a practice marketing question related to that. Okay. Because I always say there are 6 things that motivate all orthopedic surgeons. It's doing the right thing, making money, marketing at practice, covering your ass, power and glory, and going home. Those are the 6 things that every orthopedic surgeon has some variant of. Have
What
you
was number
noticed?
5?
What?
What was number 5?
I forgot number 5. Yeah, they're all number 5. So in market, have you noticed, Paul, since you have been decreasing the pain more, has word got out that you're the pain-free shoulder guy?
No, that stays with a guy called Scott Sigmund in Massachusetts. I have not quite got that title yet. No, look,
No,
I
I don't
think
mean opioid sparing. I mean patients telling other patients, I had a good experience.
yeah, look, that's how, whether good or bad, I think that's how most surgical practices develop, at least in private practice, especially where we are in proximity to a big city where there's no shortage of surgeons. Patients don't just flow into you, referred by a sequence of orthopedic surgeons who don't want to do the case or internists. It's really word of mouth from surgeons, from patients and how they've done well.
So I have another question from Marty. Is there a point that total pain relief post-op could become detrimental to an outcome? For example, could a patient become active too quick because they're so pain-free?
Shit, when we get there, I'll be so happy, right? Yeah, I guess too much of a good thing, but look, I'll take that. That would be a good problem to have.
Right. They really have to convince them. I know that.
So Paul, Ira's question to you, and I'll send it back again. I think that as time goes on, you don't choose your practice chooses you. And if you have this reputation of being able to do this great shoulder surgery with minimal discomfort, you're going to get a bunch of patients flowing in. And I give minimal, no narcotics for almost anything I do. And I was talking about with my MA, I think that the calls up for a refill for the 5 or 7 or 9 oxycodone 5 milligram tablets that I give for a rotator cuff repair is in the single digits. But I think that one of the things that we need to think about in that situation is it because we're doing such great, minimally invasive, reasonably pain-free surgery, or patients who need a lot of pain medication just aren't coming to us because they know you're not going to get a lot of pain medicine.
Yeah, look, that's people are going to select us, and I think they're absolutely going to find people who historically may have been pain pill mills, whether good or bad, and I don't know if legislation is the answer on how we should solve this, but it's made it a lot harder. And in a bad way, patients who suffer from chronic pain have a very different battle to get into here. Thomas Evely, I see you on the horn. Thomas is a surgeon in Alabama. Thomas, how does this pain stuff transpire, or how does it play out in a different population in Alabama, much to what Mike and I are alluding to?
Yeah, that was going to be my question to you, is because I have a not a small proportion of patients that are on chronic narcotics when they come to me, and one of the things, I'm only a couple of months in. One of the mistakes I have learned from quickly is identifying those patients and making sure I recognize going in the ones that are on chronic narcotics before surgery, because it's a daily battle for me calling in for refills. I'm not as slick as Dr. Sethi on my rotator cuffs, so they take me a little longer. So my post-op patients probably have a little more pain than most. But I'd love to hear your comments on, if you have a patient on a chronic narcotics, does it change your approach? Because I'm using the multimodal protocol that you use, but I still get a lot of medication refill requests for rotator cuffs and actually less for my arthroplasty than on my rotator cuffs.
Yeah, look, as you know, psychiatric disorders and chronic use before, and that's up to only 3 months. It's going to make it harder. You're going to have to give more. And my best strategy, it doesn't work so well, is having them identify where are they getting their pain medicine before and who is their pain management doctor. Hopefully it's not just their internist, because then you're really in a pickle. Because then it's a little of this. but if they have someone who helps them manage them chronically, because you're not going to get them off, they're going to need it for longer, and you're wed into a different game.
So Paul, I have a little bit of a different approach. And Tom, if I have a patient who is on has chronic pain and chronic pain medication, we have a little contract ahead of time. And the contract ahead of time is if you've been getting your pain medicine elsewhere, that will continue to be your source. I said, we're going to have the expert treat that. I'm not going to pretend to be able to treat that. And I will give them no narcotics afterwards. And any kind of medication they need that's narcotic in nature has got to come from their pain clinic doctor, and we give them zero. And that's an agreement we do ahead of time. And I think it's a good agreement because I said, listen, I'm not the expert on pain medication. I try to minimize as well. If you're in that situation, you need to be dealing with the expert, and it's not me. There should only be one person in charge of your medication. And in this case, it should not be me.
Yeah, and thank you for that. I think that's where, I'm only a couple of months in, and the mistake I made early was recognizing on the day of surgery who was on those chronic narcotics, because in the clinic I was focusing on who am I operating on, and other things. Are they on any blood thinner medicines? And I go to an ASC and in a hospital, so who can I take to which facility? And I let that kind of slip through, and having those discussions in the clinic, I think are very important too, as far as where they're going to get their pain, the multimodal approach, but also where they're going to get their pain medications post-op. I think doing that before surgery is a quick lesson I learned in my first few months of practice.
Tell them it should not be you.
What was that, Neil?
How old are your patients?
So I take care of a wide swath. I operate on
I'm
a
asking Tom. I'm sorry. Here, Tom. How old are your patients?
In general, I'd say 40 to 60. They tend to be older. They're not so many athletes. I would put them in the 40 to 60-year-old category for the most part.
Okay.
So Paul, we have like 3 minutes. I just want to make a couple of comments and then ask you for a final comment. I want to tell everyone that this is recorded. We're going to edit it. We're going to pass it on to Paul for approval, and it'll be posted on a YouTube channel and Doc Social channel. Additionally, I want to direct people to Paul's article on the journal. I think it is, I don't know, I feel it's a landmark piece. It's written so well, and it's probably going to go over 1,000 views within the next week, which is a testament to a lot of good work by your colleague, Dr. Commodore, and yourself. So Paul, maybe some final comments for everybody?
Yeah, well, first of all, thank you, and thank you to the journal. I think you've started another great thing, and I like an open access where we're not sort of compelled to pay and be in a bad spot to get great knowledge. I do want to acknowledge Parth Kamdar. Parth is currently a medical student who's matched in orthopedics and just married, and he's really a superstar. So shout out to him. And then look, each of us are going to handle this slightly differently, but if we can start to accept some sort of framework or protocol and how we're going to approach this, and stay within that framework on how you approach patients, then I think we can come to solutions that are repeatable and eventually don't get us into the same hole that we find ourselves in currently, where we've got a world of imperfect prescription. And as we advance the science of surgery, I think we have to advance the science of postoperative pain control in the same way.